Hello.
Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out the program evaluations. And I'll again ask you, as I always do, to give us any ideas that you might have in regards to future topics and future speakers. Today I have the pleasure of reintroducing Dr. Ricardo Arbulu. Dr. Arbulu is board certified in internal medicine and also infectious disease, and he in fact is the Department of Infectious Disease at Mary Greeley and McFarland, and also the most recent recipient of the Mary Greeley Excellence and Innovation Award. And he's here to update us on the diagnosis and management of asymptomatic bacteriuria in adults. And please join me in welcoming Dr. Arbulu.
Thank you. Hey, everybody. Thanks for coming. Well, the title was catchy, right? So we are not going to talk about UTIs. We're going to talk for the next 45 minutes about this condition called asymptomatic bacteriuria that is not something that appears to be on people's mouth too much as it needs to be. What motivates this talk is the issue of antibiotic overuse. This is a global problem, and the US in particular. As you probably know, overutilizing antibiotics is associated with the current C. diff colitis epidemic that does include Mary Greeley. It's associated with increasing antimicrobial resistance worldwide. And of course, it gets to the whole issue of unnecessary care. You simply don't want to give medication that does not to be in, because everything has side effects. This was in Fox News this month. And what they were discussing here is the following study. CDC puts out periodically a study or series of studies called CDC's Vital Signs. And in March, they happened to address the issue of antibiotic overuse. So in this table, they are showing a survey that they did on a convenience sample of 183 acute care hospitals across the nation, in which they describe what are the most common indications in a hospital to prescribe antibiotics, whether it's appropriate or not, which are the most common. Lower respiratory infections is number 1, and UTIs is number 2. So of this 11,000 people, 993 received antibiotics for UTI. So 13% of everybody who received antibiotics received it for UTIs. And then they went on to try to guess how much of that was appropriate and how much was inappropriate. And they came up with 39.6 or 40% of inappropriate use. Based on which criteria? Things that seem pretty obvious, right? So, well, if you do not order a urine culture, how can we tell that you have UTI, right? That's pretty standard treatment practice. And so they counted those. I'm sorry, and this is not the whole sample, but more like a sample within those 11,000 people. They just randomly picked up 111 charts, and these are the actual absolute numbers of what they saw. So this is just a sample within that. Obviously, all the statistical means to do this were respected. And my point here is what I have circled here, that a lot of people had urine culture positive, but nowhere in the chart they could find symptoms of UTI. So you read this and it seems logical. Yeah, why did they get antibiotics? That's misprescribing, and that was 20%. Well, that has a name, and that's called asymptomatic bacteriuria. So this happens elsewhere, right? Happens in 183 acute hospitals, but doesn't happen in Mary Greeley, correct? I want to go over this case with you guys. It's a 3 slides case, but it's worth because it's kind of an outline for the rest of the talk. So let's read through it, and there's a question at the end, of course, depicting the challenges of this situation. So this was a 78-year-old female that came from an assisted living. She had diabetes mellitus type 2, which was well controlled, hypertension, hyperlipidemia, COPD, and urinary incontinence, all of which is kind of a frequent combo. She presented to the emergency room with chest pain, dyspnea, feeling poorly, all over one day. Can you hear me well? Okay. Temperature was 99.1. Heart rate was 112. The exam was unrevealing other than anxiety, and she did have a fluctuation or a peak in her troponins. So I'm trying to hint you in that she did have a non-ST elevation MI. The CT angiogram done to evaluate her chest pain and dyspnea was negative for pulmonary embolism. Since she was complaining of this non-specific malaise, a urine analysis was ordered as urine analysis reflect the urine culture if abnormal, and that's a common order in the emergency room. Since the urine analysis showed leukocyte esterates positive and nitrates positive, the patient got a urine culture reflected. The microscopic UA did show pyuria, right? Cells, leukocytes, a little bit of red blood cells, and this goes along with leukocyte esterates, right? The patient was started empirically on levofloxacin because they saw this nitrates, leukocyte esterates, and the white count. And 36 hours later, we get this growth. There's an E. coli that happens to be an ESBL, so an extended spectrum beta-lactamase producer, susceptible to cefepime, imipenem, Bactrim, and macrobid, everything else resistant. So the patient, this is a follow-up at that point at 36 hours. Her chest pain has improved. She continues fatigue. Temperature was normal. She denies any urinary symptoms. She did not have CVA tenderness. She's allergic to sulfas. I think I failed to mention, yeah, she did have cardiac catheterization. So what is the next best step in management? And I want, at this point, I would appreciate an honest answer of, you are here hearing about asymptomatic bacteriuria. You probably know what I want you to answer, but I want an honest answer of if you got such patient in the middle of the night, what would you do for them? And somebody's playing with my computer here. So I think you can go ahead and answer now. Switch to one of the antibiotics IV that she was susceptible to. Switch to an oral antibiotic, which was susceptible to. Stop and no antibiotics, or consult ID infectious diseases before anything is done. I'm getting 19, 20, 21. Just give it a little bit more. And again, honest answers kindly. People are still clicking. Okay. 27. We'll allow one more. Go. Okay. So people honestly are saying they would stop levofloxacin, and you got a hint from what I've been presenting that that's the right answer. So review of basic things that are necessary to be able to move forward. When you get bacteriuria, right, bacteria in the urine, this could be from pyelonephritis, so infection of the kidneys, in which case you would expect the patient to have a combination of fever, chills, nausea, vomiting, and CVA tenderness. Of course, not usually the whole combo. You can have cystitis, inflammation of the bladder, which typically goes with dysuria, polyuria, urinary frequency, willingness to urinate without being able to, urinary tenesmus. People do present with increasing chronic incontinence. That's another actually frequent symptom in elderly people. Of course, you can have a male reproductive tract syndrome that it's a little bit outside of the scope of the talk today, but that's another cause of positive urine cultures. Now, you could have none of the above. You can simply have a contaminated specimen, right? So the patient needs to give you a midstream voided urine, and that's never a perfect process. They need to, clean well the genitals and then give you a good sample so it doesn't get dirty. But there's lots of opportunities for that sample to get dirty. The urinary meatus right here is easily colonized, the whole perineum is, with all the flora that comes from the rectum and the anus. From the vagina as well, And at times there's gross fecal contamination. People are fecally or incontinent of stool. So there's a lot of reasons why the urine can be contaminated. But what I'm introducing today, in case you're not familiar with, is that you can legitimately have bacteria that comes from your urinary tract, typically the bladder, but does not cause symptoms. And that's another differential diagnosis of bacteria in the urine. So if we were to summarize what the Infectious Diseases Society of America wants us to know about this, we go back to those guidelines that were published in 2005, almost 10 years ago, and haven't been disputed, basically because they have good evidence backing them up. Anybody's familiar with these guidelines? Raise of hands, kindly. Leanne doesn't count because she's... so 1 out of 100 people, I'm not sure how many are in the audience. These are good quality guidelines, unlike most guidelines that the Infectious Diseases Society of America puts out, because there's randomized controlled trials backing it up. Mostly guidelines come up when, we don't know, there's no good evidence, yada, yada. This one is pretty straightforward. And I think this slide says it all. So how do you diagnose asymptomatic bacteriuria? Well, no symptoms of UTI, yet you get a positive urine culture. And the caveat here, which in practical terms you don't need to worry about, and I'll come back to this, is you need to have a colony count about certain diagnostic threshold, right, to differentiate this from contamination. Because, the logic is, if you get a little bit of bacteria there, you can assume that actually came from the perineum or something. But if it comes from the bladder or from the kidneys, you would expect a greater load of bacteria. And I apologize, this didn't translate well. This is supposed to be 10 to the 5, so 100,000 colonies, the typical number that we are all used to hear for diagnosing pyelonephritis or cystitis with a midstream voided urine. The same threshold applies to this. But again, in most cases, as we will see in this particular case, it suffices to know this could be contamination and this could be asymptomatic bacteriuria. I know I'm not going to treat either. I know this lady does not have cystitis. I know she does not have pyelonephritis. The management of such culture is the following. We don't need to look for it in the first place, so do not go screening people around for this. And if you find it, simply do not treat it. Of note, this is not only of no benefit, but for many people it's going to be harmful. Needless to say, it's going to be costly. Except, and big exception, again backed up by good evidence, in these people. Pregnant women, they do need to be treated if you find a urine culture positive, and patients who will go urologic procedures with mucosal injury. The evidence actually is specific for transurethral resection of the prostate, but it's reasonable to extrapolate to other procedures. This is not the focus of this talk because we do well on this. People do well on this across the board because this is typically taken care of by gynecology and urology, respectively, in a very protocolized fashion. They don't need to think about it. Every pregnant woman gets a urine culture and that gets addressed. Seldom you will find a random urine culture done on these people. So what we are more interested in addressing is that other population that gets random cultures for various reasons. And just to drive this home, again, the thresholds exist mostly to differentiate colonization from true presence of the bacteria in the urine. We're just trying to guess by giving these thresholds. And this is very important for research, so they have a unified definition. And when we read about asymptomatic bacteriuria and when we present articles like I'm going to present to you in a second, we know that we are talking about that and we're not talking about colonization. But practically speaking, you don't need to worry about that for when you encounter these cultures. This little table here is just a depiction of how these famous thresholds got generated. The original studies that come up with this 10 to the 5 colonies, which is kind of an arbitrary threshold, were done in the 1950s, and were basically doing this kind of a grid, comparing or trying to count how many people who get a first positive urine culture get a second one. What is the threshold for getting a second one positive, assuming that determines that there's true bacteremia. So there's a study for asymptomatic bacteriuria done in that fashion in 1956. That term was utilized by Cass, who also came up with the threshold that we're all familiar with for pyelonephritis and cystitis, which happens to be the same one. Another point to be made here is that when you have a straight catheterization, for obvious reasons, you get a cleaner sample, you are not that demanding, you do not want a threshold that is that high. If you find some bacteria, you assume it's real, and that's why we have a 10 to the 2 and not 10 to the 5. Further, the IDSA, again, mostly for research purposes, they require 2 samples, and that's what the studies that I'm going to be quoting mostly utilize. So, in addition to the definition, a main take-home message from today is how frequent this is. Again, thanks to being able to diagnose asymptomatic bacteriuria, we can find a prevalence, a true prevalence of this. And you can see here that even in premenopausal women, this is all women without catheters in the urine, because that changes the whole game, and I'll come back to that. Women without any catheter and with the following age groups and conditions. So premenopausal women, they would have anywhere between 1% and 5%, depending on the studies, the definition, the specific population study. That's why you see a range and not a single number, because this is basically pooled studies over time. Pregnant women overlaps probably slightly higher. When you get older, you get more bacteriuria, and you can see that trend. For people over 70, around 15% of them have bacteriuria, and we're talking women, at any given time. Again, these are all asymptomatic people that were studied for research purposes. Now, look at this. When you get into a long-term care, your chances of getting bacteriuria are as high as 50% in some studies. And this goes along with the fact that these people are less functional, so they get up less, they go to the bathroom less, they have a lot more bacteria accumulating in their perineum, which is more opportunity for bacteria to crawl back and colonize the bladder. Also, they have a lot of comorbidities that predispose them to have bacteria growing in them. And once more, these are all asymptomatic people. You can see, other comment that can be made here is the range here. Again, we give a range, not a single number, but see how consistent the studies are. In several studies done in people greater than 70 years of age in the community, we get always the same range. When we get to diabetics, what we learn is that diabetic women have, in general, more asymptomatic bacteriuria than their counterparts that were not diabetics. And this large range that you see here is because we're including diabetic women of all ages. That's it for the women. Now, this is something very exciting, and may not be the whole story, but it's a very provoking explanation that certainly has accounts for some of this that we are seeing here. So what research has found in this article by Clem, that very catchy, was entitled Mellowing Out. They find that that uropathogenic E. coli and asymptomatic bacteriuria E. coli, so here term UPEC, specifically this prototype with letters, and the prototype 83972, which is kind of a recurrent asymptomatic bacteriuria bug in the literature. So they found that these are different animals, literally. The uropathogenic E. coli has adapted to survive being essentially a parasite. It has developed fimbriae that allow it to adhere to your bladder and to crawl, ascending to the kidneys. it has hemolysin that damages the epithelium. So bacteria are not evil beings. They're just trying to survive, and this is a way that E. coli uropathogenic has found its way to survive. In fact, it can cross the blood thanks to this hemolysin that basically perforates the tissue and goes through. But the asymptomatic bacteriuria has mellowed out. It's like your grown-up child that doesn't want to move out and has figured out an easier way to do things, right? And here it is. So how do we fight over that flow of urine that is coming all the time? Well, just chill, reproduce more frequently, so more bacteria stays in the bladder. We don't need to go through a trial of adhering to the epithelium. We're just going to reproduce a lot. And no need to ascend. We'll just chill out in the bladder. And, well, of course, when there's biofilm, there is another opportunity to stick around without much effort. This is a beautiful study, and this is actually a copy-paste from the original study. And as we'll see, it's probably not the whole story, but it's really, really provoking. Certainly, it has been demonstrated that this is more frequent in asymptomatic bacteriuria, and of course, this is a typing that is not available in clinical practice. So back to our patient. I think people are convinced, and probably you guys were convinced since the first time, that she has either asymptomatic bacteriuria or some colonization, because we didn't do the exact criteria there. I mean, she didn't have 2 different samples. But we know there's bacteria that are not causing pyelonephritis and no cystitis because she's not symptomatic. Treatment is therefore no antibiotics. So people may be wondering, are you sure? The patient is diabetic. And people may come up with this very true fact. UTI is more frequent in diabetic than non-diabetic women, and it tends to be more severe. We have this pneumatosis on the bladder and all sorts of complications. What about having pyuria? This woman had 25 to 50 white blood cells. So doesn't that mean that she is inflamed and we need to take care of that? And finally, I did make the point that we found an ESBL on that patient. She had a very, not aggressive, I would say, a very resistant organism to treat that we don't want to spread. So the data that we need to address that is a randomized controlled trial to see, well, treatment is beneficial or is it not beneficial? And they already did that, and that's part of the quality data that is incorporated on these guidelines done 10 years ago. So this group in Manitoba, Canada, which is very active in studying asymptomatic bacteriuria, enrolled 1,900 adults greater than 16 years of age without any symptoms of UTI. They were attending a clinic for diabetes. So they screened them with the 2 different cultures, and 135 of them met their criteria for asymptomatic bacteriuria. And if you do the math, that coincides with the prevalence studies that I just showed you. The people were randomized, again, all this is blind up to that point, to receive to the treatment arm or to the placebo arm. In the treatment arm, what they did was something aggressive that certainly is overkill for cystitis, as we know at this point. They did Bactrim or Septra, or ciprofloxacin for 14 days, depending on allergies and susceptibilities. They rechecked the urine at the end of those 2 weeks. If the patient was positive, they retreated. If the patient was positive yet a 3rd time, they said, let's give them prophylaxis. And they did that for up to 36 months that the study lasted. For legitimate reasons, many women were lost to follow-up, but I think this is still quality data, as I'm going to show in a second. The placebo arm was a real placebo study. So they gave them pills that were identical to either the trimethoprim sulfa or the Cipro. And the outcome variable of the study was actually to see how many of these people actually get UTIs that they can feel, right? Pyelonephritis or cystitis. So the use of antibiotics for that indication was rather an outcome variable, and that was allowed in these women whenever it happened. So I think you can still see these numbers, but the bottom line is here to your right of the screen. This is table 1 of the study, and I want to make sure people notice that these two groups of 50 women in one arm and 55 on the other arm were comparable in relevant variables. So they were about the same age. We're talking about women around 57, the same race. They were equivalent in their history of UTIs, history of gynecological surgery, their sexual activity, glycemic control, which was, by the way, pretty bad. Here, their hemoglobin A1C was 13.2 in one arm and 12.7 in the other arm, which I think supports the notion that, well, if somebody's going to get UTI, it's these women. And they were also similar on what organism was recovered. So there was E. coli, Klebsiella, etc. E. coli being the most frequent as expected. So let me walk you through this result table. So as I said, some women were lost to follow up, so it's important to notice how long were they actually followed up for. The placebo people, 790 some days. And this is, by the way, expressed on means plus minus standard deviation, okay? So that's why you get this plus minus and another number here. But you can see that they were followed for over 2 years in both arms, and there was not a significant difference when we do the p-value. So now let's look at the actual results. So how many events per 1,000 days of follow-up did these people have? So if you take all the symptomatic UTIs in the placebo arm, 1.1 per 1,000 days. In the other arm, 0.93, no significant difference. And that was repeated for cystitis alone, for pyelonephritis alone, for any UTI requiring hospitalization. No difference, as you see here, the p-value is greater than 0.05. Bottom line, you gave antibiotics to these people here in the treatment arm for up to 36 months, and you achieved no difference on the symptoms they felt on cystitis or pyelonephritis or their requirement for hospitalization. What was different, of course, was how much antibiotic they got. The days of antibiotic use for UTI for 1,000 days, this should say in follow-up, including the study antibiotics, of course. We want to include that. So when you compare that, of course, the placebo people, well, at times they did get UTIs, they get some antibiotics. That adds up to 33 days in 1,000 days of follow-up, whereas the other guys got 158, and that's a remarkable, significant difference. There were more side effects in the treatment group. The difference in this small study was not significantly different. To drive that home, we can look at a survival curve, which shows you slightly different data, which is how many of the women actually did not have symptomatic UTI at any given time. At the beginning, nobody had it because these were all asymptomatic bacteriuria people. And so this is 100% or 1. And then with the months, of course, you expect this to drop as many people do fall to UTIs. So as you see here, this is basically even out. And you can argue that the antimicrobial therapy group was slightly better at the end of the follow-up in over 30 months, but when you do the statistical analysis, and in that I'm trusting them because I couldn't decipher the test use, but basically this number is no different from this number. So you gave antibiotics all this time and achieved no difference in preventing an actual UTI. If you hadn't screened these people, if you hadn't done anything, they wouldn't have felt anything. So conclusions, antibiotic intervention did not reduce the rate of subsequent UTI or the use of antibiotics for the same in a cohort of women of various ages, but means 57 years old, not shown in the table, it's the time to the first UTI. So, I mean, you received antibiotics at the beginning or you were assigned to placebo. The UTI occurred, the first UTI occurred around the same time. The guidelines are very clear. There's no role of screening diabetic women for UTI. I know you need to get another urine test there, right, for microalbuminuria. But make sure to either not do a urine culture with that, or if for some reason it gets done, you don't care about it. right? I mean, that's what it needs to be done, and that's better care than taking care of that blood culture between quotations. So back to our initial case, people said, well, she's diabetic, we should treat her. I mean, we made that point. We should not treat her. Now, how about that pyuria, those white blood cells? Typically, that should indicate inflammation in your bladder. We should treat inflammation, right? Well, if you look at patients, the universe of patients here are already all those patients who do have asymptomatic bacteriuria. Again, nobody's symptomatic in this chart. Among those, how many have pyuria? And you see that pyuria, white blood cells in the urine, is fairly frequent. The older you get, this is a recurrent theme as you see, the older you get, the more likely to get pyuria. The more morbid you are overall, the more likely you get to get pyuria. In people who have long-term catheters, and I'll show you a different graph depicting the same, we can assume that at one point in time, once at least 21 days of catheter have gone by, these people have all been colonized and they all have bacteriuria. They all have pyuria. We're looking at the white blood cell counts at this point. Bottom line, pyuria is frequent. Therefore, it doesn't help me decide whether these people have something else. Bacteriuria, asymptomatic bacteriuria comes, quote unquote, the combo comes with pyuria most of the time. That's the message with this slide. The third argument that people may make is, okay, she had a resistant bug. I let it go? And the best evidence, which is kind of indirect, but it's logical, is looking at what is the microbiology of UTI, namely cystitis and pyelonephritis, and compare it to the microbiology of asymptomatic bacteriuria. And it is similar. If you grab young adults, they have, well, most of them will have E. coli. Staph saprophyticus is a common cause, a relatively common cause of cystitis in young women. And then you have your Enterobacteriaceae, Enterococcus, Streptococcus group B, and rarely in that age group, Pseudomonas. When they do the studies on asymptomatic bacteriuria, they replicate this. So there's really no difference. It's kind of the same bugs doing this. It might be, just to keep the consistency here, it might be that we have a mellow version of each of these bugs. We only know that for E. coli. There's no studies to date that I'm aware of that would describe that they're species exclusive to asymptomatic bacteriuria of this. But the point in case is that you're getting the same pattern that in symptomatic UTI. This is to depict older adults. And as you see, as you get older, you trade some of your E. coli for Pseudomonas. And this is a question we get frequent. Like, I've been asked in recent memory within the past week, I remember somebody asking me, well, they got Pseudomonas, that's rare, right? When you get older, it's not that rare. And you start picking up some polymicrobial infections, you start seeing more than one bug. When it comes to catheters, if you have a long-term catheter, your E. coli is no longer the king because it's easier to get all sorts of bugs. And it's easier to get polymicrobial infections. Bottom line from all this, the microbiology is the same, and therefore there's no, that wouldn't let you decide what to do with that culture. You have to look at the syndrome. We already showed you good evidence that asymptomatic bacteriuria doesn't do well or doesn't need to be treated, at least in that diabetic patient population, and I'm going to show you other randomized controlled trials in a second in one table. Now, what happened to this beautiful theory about the mellow bug here being different than this one? It seems that any bacteria can cause asymptomatic bacteriuria, so the host appeared to be more important than the pathogen. So, again, you see the same pattern in age groups. If you're a young adult, you're going to get a UTI, it's going to be E. coli. If you're going to get asymptomatic bacteriuria, it's going to be E. coli. And you get older, you're more likely to get a Pseudomonas in Eiter syndrome. We need to learn a lot more about this. But the point in case is that this little interim summary here. So I think we've talked this quite a bit. Do not screen diabetics for the evidence that we just presented. Significant pyuria, almost universal in elderly patients with bacteriuria, and in other populations is frequent. So it doesn't help you differentiate. It doesn't give you any additional information. If you have a resistant organism, it doesn't really help you distinguish whether you have, excuse me, I'm going backwards now. It doesn't help you distinguish whether you have symptomatic UTI or asymptomatic bacteriuria. What does help you distinguish? Three things, right? Symptoms, symptoms, and symptoms. Where everything fails, interview and examine the patient. That leads us to case number 2. What if now you get this 91-year-old nursing home resident who has severe Alzheimer's dementia, who cannot refer a history, and she has this history of recurrent UTIs. She's chronically incontinent of urine. She became agitated 24 hours ago, and she's threatening the staff in the nursing home. Her temperature is slightly above her usual, as you see there. You are told by the nursing home there's no recent change on medication. She's not diabetic. She does not have any other major comorbidities. They did go ahead and do a dipstick, which is positive for leukocyte esterase. The urine culture was obtained right away, and now it's 24 hours later. She's still agitated. You get 100,000 CFU of gram-negative rods. The daughter dropped by in the nursing home earlier, and she's sure the patient has a UTI because this is what happens to mom. You're on call at 3 a.m. at Mary Greeley Medical Center, and this is a real patient, but this is adding a little spice to it because the call was not at 3 a.m. And you get a call from the nursing home requesting an antibiotic. How would you honestly proceed again? Asking your usual practice. Would you start levofloxacin? Would you order to start levofloxacin if the temperature is greater than 99? You would do that, so order if the temperature is greater than 99, plus advise hydration, request that the nurse practitioners who round on our nursing homes locally rounds on this woman within the next 24 hours, and then you would document what you did in EPIC and forward the note to the primary care physician, or you would do some of all this nice combo, but not all because it's not realistic or you don't think it's necessary. And responses are still popping in. Okay, we have 23 people. We're going to stop there. So most people chose 3. Obviously, the longest answer is because we want you to do that, and seems logical, right? How often does that really happen? I visited with nurse practitioners who take care of the nursing homes. Amy, I spoke to her last week, and part of her frustration is when she goes back to see these patients, there's no documentation of what happened overnight. And understandably so, people are busy and whatnot. So there's one point of improvement there, and it helps keeping track of what happens later. We'll come back to that. I just wanted to make sense of this. When you're older, you have more chances to get asymptomatic bacteriuria because of these reasons. In males, basically the prostate enlarges and you retain urine. In women, the estrogen depletion causes bacteria to be more frequent. And this is the one slide I had on men. I hadn't mentioned men before, just to show what is true pretty much for any age group. The men would lag behind a little bit on their frequency of bacteriuria, but when you get to this old age, it's still high. I mean, you can get up to 40%. Okay, that was a little excursus. I'm going to skip this one to show you again, back to the point, okay, how do we deal with this patient at 3 a.m.? Again, randomized controlled trials, and we have several of them that are here for your review, and this is in the guidelines, that showed repeatedly in several populations of elderly people, see that average age of this study is 85, 83, 80, 81, whether they are in the community or in an institution, they show that there's no difference in symptomatic UTIs and in other outcomes such as mortality when you treat this versus not treating. So in the interest of time, we won't analyze each. I went in detail over that one, randomized controlled trial, so we get a grasp of how good the evidence is. Some of this, though, I should say I got a chance to review. They're not the greatest studies. We're talking about 50 to 55 people. Some of the outcomes are probably not realistic, like they try to decide mortality based on one dose of Bactrim given a year ago. So at least there's some consistency in this data. And we have that powerful study on the diabetics that I think is the one that I would take as better evidence that asymptomatic bacteriuria is probably not a threat. So here's some tool that I would like to share with you guys. There's nothing new. This has been out since 2001, which kind of can serve as your surrogate when evaluating those people that cannot refer you symptoms. So as we said in our interim summary, what you need to decide whether to treat them or not is symptoms, symptoms, symptoms. But these people cannot give you symptoms. They're confused, they're demented. So there's criteria that by no means, to the best of my knowledge, have been studied prospectively or in randomized controlled trials or whatnot. But they are a consensus of experts and seem reasonable. That's the best we get to date. And this is already over 10 years old. But you'll see many institutions have this in their guidelines. We're talking about the LOEP or LIP, I think that's how you say it, criteria. So let's start with without an indwelling catheter. People who do not have an indwelling catheter, typically we required a cardinal symptom, whether it is dysuria or fever, with the most valuable input here that what we consider fever on these people, because they're elderly, is lower than what we consider fever in otherwise younger people. Conveniently, I mean, this is evidently not evidence-driven because it's such a nice round number, 100, but I guess it's a very fair compromise there. So fever is 100 or interestingly, 1.5 degrees Celsius above the baseline or 2.4 Fahrenheit. You can find this in UpToDate. This is evidently a copy-paste from UpToDate, and I will make it available as a dot phrase in EPIC briefly in the next week. So you can pull it up when you're seeing these people at 3 in the morning. And again, one cardinal syndrome plus one of the following. Neo-worsening urgency, very frequent. Frequency, suprapubic pain, gross hematuria, CVA tenderness, urine incontinence. Nowhere in here is mentioned smelly urine, which is the #1 reason for getting a urine culture anywhere. It is mentioned, though, in these other older criteria that are a little bit more cumbersome. Changes in the character of urine, and in the small font, it considered, how it looks, how it smells, and yada, yada. Again, these are experts sitting down on a table and trying to come up with something. I think the main message here is never use smelly urine as your one reason to check. Incorporate it into this criteria. You can make a customized LEP criteria per nursing home, knowing your staff, per patient, per family. This is, guidelines are guidelines, experts' opinions is experts' opinions. It's better than me telling you what I think needs to be done. But we get to the evidence-free zone here, and let me tell you what I think needs to be done, because, and this is based on my personal experience in my time here. So I think that the intervention that is most likely to help this patient is nothing that you're going to accomplish in that 3 a.m. call. It's unfair to put all the pressure of antimicrobial stewardship on that poor physician who's admitting 20 patients at that time. What we want is to be proactive. What we need is, I propose it to do it this way, but what you want to gather is the spirit of all this. A 30 to 60 minutes appointment that this patient needs to have with their primary care physician. You can utilize infectious diseases as your resource to have that, in presence of the daughter, ideally in presence of a nursing home staff. And we need to address the recurrent UTIs. what will we accomplish or what will we do during that visit? First of all, does this patient have UTI? That's always the first question. Why are urine cultures checked on this patient? Identified other triggers of her acute delirium or acute problems that she's always having. Basically, do the good old-fashioned H&P that is relevant. Seize the opportunity to educate the family and the staff on this. And finally, come up with, instead of just copying this and sticking it on the nursing home, give this personalized for the patient. What, in my experience, that's the one thing that works at the end. You reduce antibiotic usage by doing this kind of approach. It takes, obviously, a lot of time. In these days of managed care and in these days of efficiency of care, etc., we are progressively will be compensated by outcomes and not by the procedures we do. So prescribing more antibiotics is more clearly going to be not the option, and this kind of thing will be. Very humbly, I present to you with my EPIC template that I can share with you in EPIC with a dot phrase. But these are the kind of things you want to ask. It would be nice to revise this with urology and gynecology and all the adult medicine doctors, family medicine, to come up with the best high-yield questions to ask, kind of a checklist approach. And for those who type their notes, this might be helpful. We have 4 minutes. This I presented on a talk on UTIs that we had 2 years ago. There is a very nice qualitative study where they survey providers in focus groups. And these are some of the themes that were identified on why physicians overprescribe antibiotics for UTI. And I put a smiley on things that we may have addressed today. So probably you have a better grasp of what bacteriuria means, what is symptomatic and what is not. Sorry, I can get rid of this. The ordering of urine cultures for non-specific changes in resident status. We gave you some kind of objective data to go by, hopefully. Uncertainty of physicians about the significance and management of positive culture result. Hopefully we gave you enough evidence on that. And concerns over liability. Now you know there's good evidence backing things up. Nobody's going to sue you when there's a guideline there with randomized controlled trials saying this is what you need to do. Last word, catheterized patients. When patients get a catheter, this is basically what happens. Every day you increase by 2 to 7% your rate of colonization. So when you reach 21 days, 100% of patients have bacteria in their urine. So keep that in mind when you get the catheterized patient who people are suspecting they have a UTI. That needs to go into your analysis. And I was going to go back here. Patients with an indwelling catheter, it's a slightly different criteria. You have different thresholds of suspicion. These people get, don't let me wrong, we need to treat these people. I've got very sick people with catheter-associated sepsis and bacteremia. In fact, that's the most common cause of bacteremia in the hospitals. That is nosocomial. And you need to have a lower threshold for them to treat them. Yet, again, it is common to have bacteria with no problems in the urine in that population. I leave you with the summary that I could read along. But in the interest of time, I won't. I think the important points here is that I want to introduce this proactive approach here involving the family and the nursing home to offload the burden in the acute setting in the moment we need to take the decision. I'll leave you with questions. If there's no questions, I'm gonna, thanks for the applause. Something like, is Dr. Brown gone? Because he's the one who likes this kind of thing. This is more thought-provoking now, not with direct implications for care, but I was just reading about this too soon ago to make it into the grand rounds, but it occurred to somebody to do a PCR analysis of urine, and that was already 2012. They found that almost 100% of random people had some kind of bacteria in their urine detected by PCR. So this challenges the whole notion that we learn in medical school or nursing school that urine is sterile. Urine is not sterile. I think we've showed you how it's not sterile with bacteria that we can detect by normal cultures, but this whole PCR thing, molecular testing, reveals a whole batch of other bacteria that we don't know about. We do not know what they're doing there, but it's reality. Our body is full of bacteria, good or bad, they're there. Thank you.